So this week we are talking about the topics of suicide and self-interest behaviors occurring in our prisons and jails. Um, this is an interesting topic, obviously related to mental illness. One thing before we begin for students at our university is that if you're watching this, it can be a potentially triggering set of slides. So if you feel like there are any issues or concerns you have either going into watching these slides or as you do watch these slides, stop at any time and contact me and I'll give you alternative assignments, no questions asked. If it does trigger some issues with you, know that your university has a therapy center that's easy to contact with free counseling. So please don't hesitate to reach out to those people. And I'd also ask you to be aware of where you watch these slides and who's around you to make sure that it doesn't trigger any negative reaction from those people. So we begin with the statement and the fact that suicide is the leading cause of death in jails in America. We can see here that in our US population overall, an approximate rate of suicide is 11 people per 100,000 people. You'll note that prison at 14 people per 100,000 people is fairly close, whereas jail is about 4 times that amount at 47 people per 100,000. One of the reasons for this is that jails house short-term inmates. Some are there for a few hours, a few days, even maybe a week. As a general rule in the United States, jails are institutions in which a person is incarcerated for a misdemeanor, typically housed for a year or less, whereas prisons are places where more serious offenders, those who have committed felonies, are incarcerated for a year or more. So prisons include people who have been there for considerable periods of time, sentences of 10, 20, 30 years, sometimes even a life sentence. Due to these long sentences, prisons contain more of a social milieu where people know each other and understand each other, and people come to accept that their life or they're going to spend a long time in prison. It still may carry risk of hopelessness and suicide, but jail seems to be a much more short-term and severe reaction for people when they're incarcerated. The other thing about jail is it has a wide range of offenders. It has people who have been arrested who will go to trial or whose charges will be dismissed, and they are actually legally innocent. They will be found innocent of charges. Jails also contain misdemeanors such as homeless people who have done something in public, maybe stolen something, prostitutes who cycle through jails, charges such as driving under the influence. And jails also house high-risk offenders such as people who've committed homicide and serious charges who are awaiting a trial and then will be moved to a prison. So they actually contain people from a variety of risk factors, from essentially legally innocent to very severe charges. Prison, in contrast, the person has been through a trial and has been found guilty and received a punishment. These are very different populations in some ways. And perhaps that's the difference, that the rates of jail suicides is much higher than prison. When you look at how people commit suicide in jail, hanging is by far the most common means of suicide in jail and in prison. These data are fairly old, but it's still the same in the current context. So we start with a basic definition that suicide is defined as the act of killing oneself. This is a rare, though obviously very serious event inside of jails and prisons as well as outside. And the person who experiences these impulses often has a feeling of hopelessness or depression, and they think to themselves, I can't tolerate this pressure, this stress, or this set of circumstances anymore. So it's a way of opting out or avoiding life or avoiding pain. The definition is usually extended to include other related suicidal behaviors or thoughts. So we can start with the most common of these, which is suicidal ideation. Idea, think as in thoughts or having the idea. In this set of behaviors, a person may not tell anyone about their intentions or their thoughts. They may not act out on them, but they may have repetitive and troubling images. It may be almost a compulsion. When discussing with a therapist, these suicidal ideations, the person may actually talk more about them and become more aware of how significant they are in their life. Next, we have suicidal threats. So in this set of behaviors, a person has mentioned something or written something down and another person has found it. We see that there are threats, that there is an intention of a person saying, I am going to do an act of some kind. And then suicidal attempts, where there's actually the use of some sort of tools or mechanisms to attempt to commit suicide. When a suicide is completed, we don't like to use the term, because it's incorrect, a successful suicide. It is merely a completed suicide. That is the correct term. So when we look at jail suicide specifically, because we have such high rates that occur in jails, we find that the type of inmate with the highest risk is a younger person who is traumatized because of their incarceration or their crime. They enter the jail compromised by alcohol, potentially, as well as drugs. They're often first-time offenders. They're not routine offenders who cycle through jail. And this set of circumstances and being incarcerated can often hit this person pretty hard and develop a really deep sense of hopelessness and a commitment to act to escape whatever sense of hopelessness or pain that they are experiencing. Some of the dilemmas for corrections begins with, in the past, this has since changed, but historically there's been very little screening for suicide risk. Now it's actually mandatory in our jails and prisons. But when you don't have a screening, that is asking questions, whether it's a survey or questions as somebody is in the intake process, that is they come into the jail from a police officer or some other mechanism, and then they go through the process of getting booked in. When they're not screened at that point in time, there's a lot of missed opportunities for people who are at risk. One of the most effective screening tools that we have is a very simple question, and it's one question. Have you ever thought about, or are you currently thinking about, hurting yourself or hurting another person? We have found that this produces very accurate responses, and a person will usually be very honest when asked this, particularly when they're asked in a private setting with an officer who has some sort of training. This brings us to issue number 2, and the issue of training. Since the correctional officers at our jails and prison are predominantly trained in issues of security and safety, in the past there's been a reluctance to also train on other matters such as mental health and therapy and screening. However, with some basic training, these officers can serve a very good function. They can recognize the signs and symbols of those at risk. They can use basic screening tools, and once a person at risk is identified, they can be placed into an extra set of care or an extra avenue of care, or mental health staff can be notified. And third, there could be limited supervision of detainees or people who are incarcerated. In a lot of our jails and prisons, we face a staffing crisis where there is far too few correctional officers and far too many inmates in comparison. This has happened despite the fact that the inmate populations have decreased non-stop for the last 30 years or so. While inmate populations have dwindled and drastically reduced, correctional officer numbers, in contrast, have also dropped. And often there's a lack of supervision, or there's areas of a jail or prison where a person is not being supervised. And of course, this can increase risk factors for suicide. When we look at the risk factors of inmates or detainees in jail who are at most risk for suicide, one of the main demographic variables is the person being male. An interesting thing happens in non-incarcerated settings, which is females in our society will demonstrate much higher rates of suicidal ideation, suicidal threats, and even suicidal attempts. However, males will complete suicide at a much higher rate. In our mainstream non-incarcerated society, this is probably due to the fact that females will choose suicidal methods such as taking an excessive amount of pills or medication or self-poisoning, which a person can intervene in such events. And males would tend to choose firearms and guns, which is a much more immediate and lethal form of suicidal behavior. However, that does not explain why the same pattern occurs in jail. Males, of course, are overrepresented in incarceration. That is, there are a lot more men incarcerated than females. However, there is still this pattern of males by rate, not by frequency, being much higher risk of committing suicide. Another risk factor is being white while incarcerated. We know that whites are a minority in prison, so perhaps there is some sort of minority status that comes into play while incarcerated. Jail suicide is also linked to the person having a violent offense. Now, this is not always the case because in jail we do have a lot of non-violent offenders in jail, but there is also a pattern where people who have been arrested for a violent offense are at higher risk of suicide compared to other offenders who did not commit a violent offense. Another factor that comes into play for risk of suicide is age. A person being under the age of 18 or over the age of 55 is increased risk of suicide, and length of incarceration. Most suicides, 51%, happen within the first day, so within the first 24 hours, and almost 30% of all completed suicides happen very quickly. They happen within the first 3 hours of being booked into a jail or prison. A jail in this case. So that shows that the booking and intake process with screening and early supervision of individuals coming into the jail serves as a very crucial point of study. Some other factors for risk of suicide while in jail is isolation. So the person may be in a cell by themselves, a private cell room, or an isolated part of the prison, and they can't, and staff can, and other inmates cannot intervene in time. There's a link to mental illness, which with 77% of suicide attempts occurring with someone with a diagnosable mental illness. I would say that there's an additional factor of mental distress, which is close, and that also comes into play for a risk factor. And one of the other key risk factors is history of a prior attempt of suicide or self-injurious behavior. This also has a screening question of have you ever harmed yourself through suicide or self-injury in the past, where people are fairly honest in providing an answer, and this can represent an effective screening tool as well. A final risk factor, particularly for jail, is intoxication due to alcohol. A lot of individuals that are brought into the jail are brought in for intoxication, whether they were driving while intoxicated or fighting or some other behaviors. By the time people are booked into prison, they've often spent time in jail or gone through the court process, so intoxication is not really an issue for prison. But in jails, we know that it's highly linked to suicidal behaviors, with 60% of jail suicides that have been completed, the person came into the jail with some level of intoxication. Of course, alcohol is a depressant, so it can increase depression and depressive thoughts, and it can also reduce one's inhibitions and make people act out in ways that they may not normally act out in. A basic list that can be used for people in jails and prisons, as we start with our basic training, is provided. Now, I will begin by saying this is not an exhaustive list, and this is very generic and very general. It's a good way to start thinking about how one would look at changes in behavior in inmates and identify those at risk. However, there are people who complete suicide that give no indication of any of these things. So it is not an exclusive end all list of what to look for. But some of the stereotypical patterns that we can think of is someone who is looking sad, feeling hopeless, and is withdrawn. Of course, while being incarcerated, some of these things may be linked to the fact that they are incarcerated, such as looking tired, looking sad, not eating. In prisons, over time, when people get to know each other more and there's a social environment, one may view inmates do certain things such as suddenly give everything away. If they have a radio or certain personal possessions, they may give them to another inmate, which sends the message that they don't need those things anymore for some reason. They may write a will or write things down. They may refuse treatment. They may completely isolate themselves. And while not an exclusive list, these things certainly provide some red flags that require further looking into by mental health staff and correctional officers to at least ask some questions and alert mental health staff that there may be a problem. So when we think about screening, I've mentioned this question, have you ever currently, are you currently thinking about hurting yourself? And usually we say hurting others because that also produces an honest response. And the prior risk, these are our two main screening tools. There's some more advanced surveys where these questions are kind of broken down into 5 or 10 more specific questions. But generally, it's what have you done in the past in terms of prior risk and what are you thinking now? These are two very basic questions, and they work in the incarcerated world as well as in mainstream society. Once an individual is identified at risk of suicide, there are several things that the jail and prison institution is responsible for doing in response. There are jail and prison standards. These standards guide the behavior of staff and guide the correct policy and programmatic responses. So close observation is where we start. This is a way that staff can routinely observe inmates who are at risk of suicide. However, a number of these levels of supervision have since been improved upon by the overwhelming presence of technology, such as the use of cameras in every cell, where at a central command someone can watch what an inmate is doing. However, it's still a good idea to have staff, correctional officers, actually make a physical appearance at the cell because it sends a message to the at-risk inmate that someone cares or someone is at least paying attention or they're being observed in some fashion. And some of the older prison and jail facilities in the country still do not have that technology, particularly in some of the poorer states and poorer rural areas in the country. So our first level is called close observation. And this is for somebody, an inmate who has maybe not carried out a suicidal threat or an attempt, but the correctional staff and mental health staff have some concerns about this person. They may have displayed some of those behaviors I mentioned before. They may have started giving things away, writing down some things that concern people, mention something to a mental health counselor. And so they are placed in a cell by themselves, and officers are required to stagger their visits. So it should not be any more than 15 minutes, but the officer will walk by the cell, and often there's a clipboard outside the cell, and they will write down their own name as the correctional officer and the time in which they checked the inmate, and sometimes they will also take a note of the behavior, such as the person was okay, or the person was sleeping or standing up or reading a book. And this is just a note of behavior over time with some observation. It also allows the inmate the opportunity to talk to the person and tell the officer anything that's on their mind at that time, or if they have certain needs, or if they need to see a mental health person because they're having a crisis or a potential issue. As I mentioned, the staggered intervals are important. It should not be predictable every 15 minutes, and this allows a much better observation of the person who's at risk. Constant observation is for inmates who are at a much higher level of risk. The person may have attempted to commit suicide. The person may be expressing some very severe thoughts and intentions. And in this case, we do want to use a closed circuit TV where there's constant monitoring from some central command, and the person can be watched at all time. However, they don't know who's watching them or when. So that is the topic of suicide, and suicide in our society is actually completed suicides have decreased over time in the last 20 or 30 years. During that time, whether we know more about it or whether it's just becoming a more practiced behavior, the rate of self-interest behaviors has increased in non-incarcerated society, and it's become somewhat of an epidemic in jails and prisons. Self-interest behaviors has long been noted in the research of anthropology and psychologists that looked in prisons a long time ago. However, in recent times, it has emerged as a massive concern, and it's also led to lawsuits as it's been defined as a lack of mental health care as the person disintegrates and tries to cope with their behavior within the prison context or the jail context. So we start once again with definitions, because definitions are important. Self-interest behavior is the deliberate destruction or alteration of body tissue without conscious suicidal intent. So breaking that definition down, we see it's harming of the body in some fashion, but in contrast to suicide, there's no intent of suicide. The person's not trying to kill themselves. They're trying to do something else. What that something else is, we'll look at in just a minute. The general practice is cutting of the skin, particularly the forearms with a razor. But it can have a wide range of behaviors such as headbutting, touching, pulling wounds, scratching, hitting oneself, hair pulling. And we also have cases which are relatively rare, though in prison, more common than you would think, where a person engages in major self-interest behavior, such as removing eyes or cutting their face or cutting off limbs or genitals and these types of very severe behaviors. At this point, for major self-interest acts, a individual usually is some extreme crisis state, whether that's schizophrenia and having delusions and hallucinations, or perhaps even bipolar disorder with the mania increasing to a point where the person loses their sense of reality and really engages in some very severe acts. You'll notice this definition from 1989 includes the term mutilation. We avoid that term because there is a meaning in the act. They're not just mutilating for the point of hurting themselves for no reason. There is a reason that underpins all of this, even though it can look grotesque and confusing, and you may not understand what the person is trying to do. So mutilation is a word that we avoid when talking about self-interest behaviors. One other facet of this behavior is that suicide is not usually a very routine behavior, even in high-risk groups. In Even in a high-risk group, a person may try suicide, a very severe suicide attempt, 2 or 3 times in their life. In contrast, self-interest behavior can become a compulsive and addictive form of for a behavior, and a person can engage in self-interest behaviors every day, and it can also become contagious. So a person can learn from another person the behavior and start to do it themselves. So to recap, self-interest behavior is without a conscious attempt to kill oneself. So another way to think about it is a person who tries to commit suicide is trying to end all feelings. They're actually trying to destroy feelings or make those feelings go away. Where a person who engages in self-interest behavior wants to feel better. So they have different goals, is the one way to think about it. One thing about self-interest behavior, while it does not have the intention of committing suicide, when it gets a routine or those major acts of suicide, it can lead to accidental suicide. So the person may not intend to do it, but they may do something to their body that is so severe that they die from it as a result. And chances are it will be classified as a suicide because it will look like one. The other facet of self-interest behaviors is that it can be impulsive. And so a person who routinely cuts or hurts themselves can actually react to finding a razor blade or finding bleach or some other way to hurt themselves and act on the fact that they just came across that at that time. This is a picture of traditionally what we call, stereotypical self-injury, with what you would call chicken scratches, which is small cuts on the wrist or the forearm. It does not include things that you see in our modern day context, such as tattoos or body modification, like this man who has put spikes in his head and implants in his forehead. He's doing this for purposes of being in a subculture, being accepted into a culture, doing it for visual purposes, and so that does not include any form of body modification. It does not also include scarification, which one sees in certain tribes and anthropology. This usually has some sort of rights towards adulthood, such as manhood or womanhood, and it's a rite of passage. This is, once again, a cultural meaning rather than a psychological meaning, which is self-injury. So this is a very important slide, and one that usually helps people understand what the processes are to self-injury and how self-injury happens. On the left, we have hyperstress, and on the right, we have dissociation, which is less stress. So most people will be familiar with the pathway that we see on the left. In this case, a person feels too much stress. They feel an abundance of emotions. They might have conflicting emotions such as depression, anxiety, mood changes, anger, shame, guilt. They may have all of these emotions bubbling up, and this is the triggering kind of motivation event. This is what's bubbling under the surface, kind of like a volcano. Over time, the person feels overwhelmed. They feel like they have an inability to cope. They feel too exposed, too sensitive, too vulnerable. And usually at some point there's some sort of trigger. The trigger could be anything, such as watching a certain TV show, listening to music. It could also be a breakup with a boyfriend or a girlfriend. There's a wide range of triggers that can occur. It could even be a bad dream or thinking back to abuse in childhood or some sort of earlier trauma in their life. The triggering point is the point in which the person says, I need to do something to remove this stress from my life, to self-regulate. I'm going to cut or hurt myself. And that is the point at which the self-injurious behavior or the self-injury occurs. The result which is surprising to a lot of people and leads to this very negative behavior and this cycle, is that it can produce short-term feelings of feeling relieved or in control or calmness as it removes those emotions. While they feel short-term benefits, there's long-term consequences because the emotions tend to return at a later date, often stronger. And then the individual still has to deal with the physical damage to their body, to which they often feel shame, and that can lead to another cycle of stress. This can be an easy pattern to think about when we don't think about the behavior of self-injury, but we think about it as somebody getting drunk. So a person may experience a lot of life events and work events and social events that makes them have hyper stress. They may feel overwhelmed and unable to cope. They may be triggered. That trigger could be you're going to go out on a Friday night with a group of people and there's going to be alcohol. At that point, the self-injury could be getting very drunk. It could be driving drunk. It could be engaged in risky behaviors while drunk. And the next morning, the person feels a loss of those emotional states, feel more calm, more control, even though they have a hangover, and have long-term consequences of, oh, what did I do while I was drunk, and what trouble did I cause, and what relationships did I harm? So if you think about it in other activities rather than drinking, and you think of it in that context as self-injury, it actually makes a lot more sense. Now on the right, we have a different pathway, which is less common. In this case, dissociation, the person feels numb, they feel lost or alone, and it has a sense of alienation. So the person feels like a little bit like an alien in society. I have a little bit of this state whenever I fly back from Australia and I get jet lag. Usually Australia is about 18 hours difference, a day difference, and the time zone is so different that sometimes I feel like I'm in kind of a dreamland because my body says that it's, 2 in the morning, but I'm in a world that's, noon in the middle of the day. So this can be a very strange feeling. And people are familiar with it, but probably not as familiar as the hyperstress. But in this environment, the person feels numb, lost, alone, disconnected, almost a sense of not reality. And self-injurious becomes a way to make them feel alive or real or to function again. So a different type of process. If you think about this pathway, you may think about the Nine Inch Nails song that says, I hurt myself today just to see if I could still bleed. That's kind of a lyrical version of this pathway. Once again, the major self-injuries can get pretty severe very severe, sorry. In the system that I research in South Carolina, there's 28,000 inmates, and there's about 60 inmates, mostly men, who at any point in time will be engaging in these type of very severe behaviors. They're usually identifiable in the system because they consume resources. They act out very fast and very severe, and their responses can usually lead to hospitalization and potential death. So in the criminal justice system, early studies by Telk found that 5% of inmates had self-injurious behaviors. It's much higher now because it's a contagion effect in the system. In the criminal justice system, in prisons and jails, it's very similar behaviors, such as in mainstream society, such as cutting oneself with things, head banging. Inmates do have access to shaving equipment. There's special shavers, so it's hard to get a razor blade out, but an inmate could also use things like a chain fence around the prison that has a little bit of sharp wire where they can use that to cut their arms. So there's ways to get around some of these behaviors in prison. Coming across bleach or cleaning solutions, and finding things to swallow. These are all a range of behaviors, although much like mainstream society, cutting oneself is usually the most common form of behavior. Much like outside of prison, impulsive and compulsive behaviors produce short-term relief but long-term consequences. There's some associations with different psychological disorders. It's interesting to note that self-injurious behavior, as much as it may sound like a mental health condition, and there's been talk of making one in the DSM, does not have its own diagnosis. It's not a mental illness in and of itself. So it's part of some diagnosis. For example, borderline personality disorder has one criteria in which self-injurious behaviors could indicate that diagnosis, but cutting and hurting oneself by itself is not actually a mental health disorder or diagnosable condition. It certainly is a sign of mental distress, however. So another way to think about this in terms of inmate populations is if one is being callous, one could think, well, so what? These people may have hurt someone, they may have murdered someone. Let them cut themselves. Who cares? So in my research, I have conducted hundreds of interviews with inmates who engage in this behavior. And what you'll find is a very complex individual who, yes, often have committed violent crimes, but when you start to explore into their life course or their early childhoods, you tend to find such levels of abuse and trauma that most of us in regular society are not used to even thinking about these people in our society. In a number of cases, they're individuals that dropped out of school in elementary school. They may have even pretended to go to school, but they just simply don't. So they've never really entered society. They've never been part of elementary school. They've never had a family that provided them basic care. In some cases, one of the children may be targeted and the other one's treated completely normal. And we're talking about levels of trauma and abuse that most psychologists in regular society will not even encounter people like this. And so you'll find that these inmates have experienced a different reality from the rest of us and have not been, they've not encountered any sort of care, whether it's a school system, a foster care system, a mental health system. They simply have not had anyone looking out for them. It doesn't excuse their crimes, but it does lead to the complexity of what type of individual we're dealing with. And in some cases, I'm surprised that they haven't acted out and hurt people even earlier than they did. So a life course theory in criminology looks at four aspects of crime: childhood, adolescence, adulthood, and then usually desistance from crime as somebody gets older and they get married and they drop out of crime. That's a typical pattern. For individuals that I research, they don't end up at that final stage because their lives happen very fast and very early. They have to grow up and fend for themselves pretty quick. And so their life is usually some sort of abusive childhood, very dysfunctional adolescence where they're already involved in juvenile crime or abuse in a foster care system or a juvenile justice system. By the time they reach adulthood, most of them are incarcerated and for long periods of time in prison. So they often have a very severe long-term mental illness, a long-term prison sentence. And so the fourth part of their life course is how they deal with things in incarceration. And for some of them, this is the first point in their life that they've received medication, care, and some level of compassion, which ironically happens in prison of all places. So you would not think that prison, as the general public and media portrays as being a cold, hard, violent place, Sometimes this is the only place where these individuals do find some sort of compassion and care from another person. So in my research, here's some real life quotes of some of the men who have spoken to me who engage in very serious acts of self-injury and are incarcerated for a long time. This man said, "My mother would beat me with broom handles or whatever she could find. She would let her boyfriends beat me too. When I was 4 years old, she cracked my skull. My mum was a paranoid schizophrenic and she would find anything she could to beat us. If she left the house, she would put my brother and me in a closet and have the dogs guard the door so we could not get out." So you can see very severe and traumatic forms of abuse, even dating back to when he was 4. This other inmate who engages in self-injury said that one time he was doing his homework and his dad said, what are you doing? And he kind of sassed back and said, "What does it look like?" The dad had a hammer in his hand. He whacked him across the head and knocked him out unconscious. And the dad just left. And so he woke up later on unconscious and there was just not even anyone around. And the dad was also engaging in sexual abuse of family members. So some of these inmates are living in truly traumatic, abusive um, childhoods and adolescence. Um, this inmate remembers at the age of 8 living in such an awful environment that he ran away from home and he found a piece of metal. He had all of these emotions that he could not express. He started jabbing himself, poke, jab, and then eventually he realized that there was something that he found value in that, and that was the start of his behavior at age 8. These are important findings because correctional staff can often be confused by the behavior if they're not trained correctly, and they may think that the inmates are doing self-injurious behaviors to control the environment. For example, to be able to move their cells, maybe so they could pick their cellmate or get away from a cellmate, to control correctional officer behaviors, to control access to a hospital so they could get out of prison for a couple of days. This is some of the common complaints from correctional officers. But when you actually do the research and you find that these inmates were doing this at age 8, you realize that this is not a personal thing, and perhaps there's another way that we can go about treating these inmates and providing them some form of mental health care. You also see that one of these inmates said that even when he would go to school, he would fall asleep because his home life was so traumatic, and then he would wake up with what we see as some sort of PTSD with terrible dreams and nightmares, and he would wake up with a start, and he would have all sorts of vivid and very violent dreams. PTSD is also difficult if someone is incarcerated because things like loud noises, like a cell door slamming or someone shouting something out, gives them that constant reaffirming stress through the loud noises. By this point in time, these inmates are in school. They may have some very serious symptoms of mental illness, such as voices, talking to them, urging them to cut themselves or hit themselves. And in the second case, the inmate who was a child at the time got a note from his parents that the principal could hit him with a paddle, but no other kids in the school got this punishment. And he had got so much abuse at home, being abused, sexually beaten, broken nose, that he just had enough. So he reacted violently and punched the principal of the school in the face. Actually, sorry, he didn't punch the principal. He just walked out and got expelled. But you can see how this does set up a very confrontational response to society when authority figures, as a mum and dad or a principal, etc., now start to represent people who can hurt you. You also see some responses here in moving towards adolescence, where in this case the stepdad was very abusive and physically abusive, and eventually this inmate gets a gun and points it at the father as standing up to an authority figure, and particularly with the use of firearms and violence in response. DJJ is Department of Juvenile Justice, and this inmate remembers that he was basically put in a restraint in a mental hospital because while incarcerated, he was acting out at other inmates and staff. And he wasn't at the stage, being in adolescence, that he wanted to talk about the abuse that he suffered and the fact that his mother had passed away. He basically had shut down. So you can see with this life course, these behaviors often emerge far before incarceration. Sometimes a person will cut and start to hurt themselves when incarcerated, but usually with these severe cases, these are generated early in life. And in a number of ways, this is very interesting because that means that jails and prisons are receiving or inheriting these behaviors. There's a lot of literature that suggests that prisons actually create these behaviors, and they may add to it in some ways, but they are often inheriting these individuals with these complex, challenging behaviors that are very hard to control and very expensive. You can see in the documentary provided that there's about, it's only 8 minutes, but now you can get a visual representation of what one of these inmates is experiencing, and they talk about their self-injurious behaviors. So what can prisons do? Well, first and foremost, any sort of medical interventions and stabilization comes first. Stopping them from hurting and cutting themselves, giving them observation, fixing wounds, and kind of stabilizing the immediate situation. As mentioned, it's a different behavior from suicide. There's different goals. However, there is an overlap. Inmates who routinely engage in self-injurious behaviors carry risk of also being suicidal. The behaviors kind of go together in a lot of cases, and that's what we call comorbidity. And so looking at inmates who do both of these behaviors. Now, they will do them at different times. So a person may cut themselves every couple of days for a period of months, but they may only commit suicide, try to commit suicide once every 5 years or so. They're different behaviors, but there is an overlap with self-injurious behavior kind of increasing risk of suicide as a separate behavior. The next thing is looking at how lethal these behaviors are, how to slow down the impulsivity, usually by supervising these inmates. And in mental health care, talking to the inmates through therapy and trying to find what's triggering them. So there may be one type of memory, one type of thought, or one issue, perhaps when family visit them on visitation day, or the fact that family don't visit them. About 1/3 of all prison inmates receive a visit of any kind any year. That means 2/3 never receive any sort of visit at all. And so this population is very socially isolated from the rest of society. So trying to find what those triggers are could probably help in addressing to reduce these acts. The next factor is looking at any sort of mental health diagnosis and seeing what that is leading to in terms of the self-injury. Having a mental health diagnosis doesn't make a person self-injurious, but if they do have a mental health condition, then that should be treated. And then also using a team approach and working with colleagues. What this means in the prison system in particular is you have different groups. Correctional officers who typically focus on safety and security, mental health staff who focus on that. You also have a range of other people that come into the prison, such as the religious services and the pastors, the other mental health staff such as nurses and social workers. Self-injurious behaviors is a very complicated problem, and therefore you need a complicated and mixed team approach to respond to it. It's not the job of, say, mental health staff, it's the job of everybody. Another facet of prison management is how do we respond to the initial act of cutting. The first thing is training officers to be calm and cautious in their responses. These are very dramatic, often grotesque, very bloody behaviors. They can produce a lot of trauma in staff. One thing I found in my research is that staff are often reluctant to say that it impacts them. They'll say, oh, it's just part of my job, and dismiss it as being not a big impact on them. However, they're human, and these things certainly traumatize them, particularly when they come across a very gory, grotesque, bloody situation. Looking at issues that reinforce the current act, so what led to it and how can we stop it? Working towards therapies that focus on behavioral changes, uh, looking at the role of psychotropic medication and seeing how much medication can work, and then using certain therapies that put these energy of the inmate into maybe another channel, so trying to just redirect them towards a pro-social form of behavior. So managing self-interest behavior in the prison can also be a bit unique just because it's a different social milieu from mainstream society. When do we use mental health interventions? We don't have a lot of mental health staff in prisons, so we have to use them in the most effective means possible. And also there may be consideration, particularly in a large prison, when to get medical interventions, because inmates can do things to their body that is so severe through self-injury that they require surgery, and I'll show you a picture of that pretty soon. And also emphasizing the team approach, as mentioned. One additional aspect of team approach that's often forgotten is prison administration. So that is usually the director of the prison, who usually there's a director of programs and services, a director of mental health, a director of medical health, a director of security. So having these directors involved and having them also have an education and an understanding of what this behavior is important. I have researched populations where each individual inmate who does major self-injury has cost the prison system $1 million in hospitalization per year. So every year it costs the prison, and that's taxpayer money, $1 million to send one person to hospital back and forth for these behaviors. So it is a very expensive problem, particularly for major self-injury, because it's repeat and it's severe. And that type of severity requires a team approach of everyone being on board, as opposed to saying, oh, that's just the problem for mental health to deal with, or that's a mental health issue, or throwing their hands up and saying there's nothing that can be done. So here we can see in prison, it can take self-interest behaviors can take some other forms because people don't have the same access to tools that they would have on the outside. So this is the plastic part of a prison razor blade. There's specific razors that they're used. This inmate removed the razor and then swallowed the plastic razor blade, which is now caught in the throat area. So we have to think about the staff needed and the transportation needed to take that person to hospital, because prisons won't have that type of medical expertise and the tools to remove that. And in this case, this is in the abdomen and the bowel area of an inmate who would swallow paper clips and would actually put small little hooks on the end. You can see they would bend the paper clip so it would actually get stuck in their body. And once again, they're not passing it through their body. It's probably going to be stuck there, so they should be taken to hospital for evaluation and potential even surgery if it's needed. So in summary, self-interest behavior is complex. It may indicate underlying mental health disorders, but it may not. And intervention should focus on a team approach with some sort of therapy and can aim at whatever that underlying mental health disorder is and triggers for self-harm. It's important as a final slide here that we recognize the differences of these behaviors, that suicide is escaping some sort of psychological pain through a death or avoidance, where self-interest behavior is actually a movement towards being alive or feeling alive. The person may feel more pain, but they're moving towards still being alive and coping In many ways, this is a coping mechanism, what we call a dysfunctional coping mechanism. Suicide, there's often an excessive amount of emotions or emotions that need to be stopped or put out. And self-injury is under or over emotions, and they need to be addressed through the use of this tool so it serves a function. The motivation for suicide is avoid anger, guilt, retreat, making a statement of some kind. For self-injury, it's actually confronting those emotions, even though the mechanism is a dysfunctional mechanism. Shame, manipulation is in some cases, but the motivation is often for coping. Suicide is viewed as one final solution. Self-injury is viewed as a short-term coping mechanism, perhaps not a solution, but one of the common things I hear in my research is, I didn't know what to do. It wasn't well thought out. It was something I had to do because I was overwhelmed with emotion. So two different processes that are interrelated. This is very psychological. Obviously has a lot to do with this coursework and mental health. I hope you enjoyed it. It's one area, particularly self-injurious behaviors in inmates, that I have a national and international reputation in, and I've published a lot of studies on it and conducted a lot of research. So I'm passionate about this study, and I hope that as the more people learn about this study, particularly those who go into the workforce, they can be part of a movement towards reducing these behaviors, both suicide and self-injury, and leading to better outcomes and reducing a lot of pain and hardship in the world for people who suffer from these things and their family members who also suffer from it, as well as staff members too, who have to predict and respond to these behaviors. Thank you.